Now let us understand the pathophysiology. So what is the pathophysiology behind heart failure? So whenever you have an initial onset, there is some trigger. It is going to trigger the compensatory mechanism, which then will lead on to remodeling of ventricles, and finally, as a vicious cycle, it is going to cause progression of heart failure. So how this is going to happen? Let us suppose MI is your initial insult. So you have the ventricles, you have myocardial infarction, and this part is going to heal with fibrosis. Even if it is replaced with the fibrosed tissue, it is not able to pump like it was doing before. So cardiac output anyway is going to reduce once you get myocardial infarction. Whenever your cardiac output reduces, it is sensed by your baroreceptors, which will then activate your sympathetic nervous system. So there will be activation of sympathetic nervous system. When sympathetic nervous system is activated, it is going to cause your vasoconstriction. It increases the contractility of your heart, increases the myocardial contractility, and it also helps to redistribute your blood from your renal and splanchnic vessels into the other parts. So there is also redistribution of blood. Now, whenever your renal hypoperfusion is going to be sensed, this is going to cause release of your renin-angiotensin-aldosterone system, which is going to cause salt and water retention. So this is going to cause salt and water retention. On top of it, it is also going to cause activation of your antidiuretic hormone. This is also going to result in your water retention. So whenever you have salt and water retention, this is going to increase your venous return, which is going to increase your cardiac output. So the person can be temporarily free of symptoms, can be asymptomatic for some time. But after that, this puts a continuous strain on your ventricles, right? So therefore your ventricles will have the myocytes which will undergo degeneration. So the myocytes can undergo apoptosis, or it can undergo degeneration, or there can be changes in the genes which are present to code for the myosin proteins. So therefore all this can affect the contractility, and the contractility will reduce greater extent, and the cardiac output in turn will reduce to a greater extent, and you will have the progression of heart failure. Now when we talk about clinical features, patients will present to you with symptoms of fatigue, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, of which the physiological bases were explained before. Chinese tox breathing. So Chinese tox breathing, the person will have, because of the increased circulation time, the chemoreceptors sensitivity is going to be altered. So there will be periods of apnea and hyperventilation, so which is called as Chinese tox breathing. And there can be right hypochondriac pain, abdominal fullness, weight loss. So these person can have weight loss because the nutrients are not absorbed because of the inflamed bowel, and therefore the person can have weight loss, which is called as cardiac cachexia. The other symptoms and signs are, person can present you with edema, a fall in blood pressure can be seen, elevated JVP can be seen. RS examination will show you crackles. CVS examination will show you displaced apex beat because of cardiomegaly. There can be S3 and S4 which is heard. And in abdominal examination, you can have hepatomegaly, ascites and icterus can be present. What are the investigations you have to diagnose heart failure? The basic investigations are the routine investigations which are done. That includes your complete blood count, serum electrolytes, serum urea creatinine, liver function test, urine routine, fasting blood sugar, fasting lipid profile, serum TSH level. Now on top of all this, the other specific tests you require are ECG. ECG will tell you if there is going to be ventricular hypertrophy or if there is going to be old MI. All this can be found in ECG. Chest X-ray. Chest X-ray is important because this can tell you if there is going to be cardiomegaly And it will also tell you if there is going to be the signs of pulmonary edema or pulmonary congestion, so which can be seen with the signs like inverted mustache sign or a bat wing sign, and you can also see in the curly B lines. So all these are your features of pulmonary congestion and pulmonary edema. So these can be seen in your chest x-ray. Then you have echo. So echocardiography will tell you whether the valves are fine, how much ejection fraction is. And next, MRI. And finally, we have the serum BNP, that is brain natriuretic peptide, and NT-pro brain natriuretic peptide. So why these gets increased in heart failure is because whenever you're going to have increased in the sodium and the water retention because of compensatory mechanism, your body also tries to remove this excess water or salt by causing natriuresis, for which it requires substances like atrial natriuretic peptide or brain natriuretic peptide or NT-pro brain natriuretic peptide. These are released mainly by your ventricles. So your brain natriuretic peptide are mainly released by your ventricles. So therefore, whenever there is ventricular failure, it is going to be increased. So this BNP levels will tell you whether the person has got heart failure or not. If the values are going to be less than 100 picograms per ml, it means that the person doesn't have heart failure. If it is going to be more than 450 picograms per ml, it is mild heart failure. If it is going to be more than 900 picograms per ml, it is moderate heart failure. When it is going to be more than 1900 picograms per ml, it is going to be severe heart failure. So therefore, your pro-BNP will tell you whether the person has got heart failure or not. And also this brain natriuretic peptide, it can also increase in your other failure like renal failure. And sometimes it can be falsely low in people with obesity. So these are the disadvantages with your brain natriuretic peptide. So of all this, the most important one is ejection fraction, which is calculated by stroke volume divided by end diastolic volume. So how do you treat the patients? So to treat the patients, you need to know about two types of classifying patients with heart failure. The first one is New York Heart Association classification, wherein the stage 1 patients are with cardiac disease, but there is no limitation of physical activity. In stage 2, they have slight limitation to ordinary physical activity. And stage 3, they can perform only less than ordinary activity. And stage 4, they are uncomfortable even at rest. So these are the 4 ways of classifying the people based on symptoms. Now the next way of classifying is where stage A belongs to people with no structural abnormalities, but they are at risk of developing heart failure. So those are people with long-standing hypertension and so on. In stage B, they have structural heart disease, but they are asymptomatic. In stage C, they have structural heart disease and they are symptomatic. On stage D, they are symptomatic, but even with medicines, they are not responding. So need special intervention. So they come under stage 4. So how do we treat? We treat the underlying cause. If it is hypertension, if it is ischemic heart disease, you treat the underlying cause. The drugs which can be given are your ACE inhibitors, angiotensin receptor blockers, beta blockers, diuretics, aldosterone antagonist, digoxin, anticoagulants and antiplatelets, and antiarrhythmic drugs. So how do you go about? How do you treat? So basically the order we are going to follow is going to be like this. When the person has got fluid retention, you first correct it by giving diuretics, and after that you start the person on ACE inhibitors. If the person doesn't respond with ACE inhibitors or uncomfortable, then you switch on with angiotensin receptor blockers. Then you can switch over with beta blockers. If the symptoms are going to persist, move on with aldosterone antagonist, and you switch on with the other drugs based on the symptoms like digitalis, antiplatelets or anticoagulants. If there is no fluid retention, then directly you can move on with ACE inhibitors. So this is how you start with the medical management. So if the person is going to have any other abnormalities, like there is rhythmic disorders, you can use cardiac defibrillators, or when both ventricles are going to have problem, you can use the biventricular pacing. This you use whenever the QRS is going to be more than 120 milliseconds. You can use biventricular pacing. And cardiac transplantation is the last option for people with severe heart failure. Salt and water restrictions are non-pharmacological measures which has to be instituted by the patients. So whatever we have been discussing is about treatment of chronic heart failure with tablets. How do we treat acute heart failure? We go on with injections. So you have IV diuretics, IV nitroglycerin or nitroprusside or necitide. When people develop headache with nitroglycerin or nitroprusside, you can switch over to necitide. So these drugs are going to reduce your pulmonary capillary pressure. So therefore it is going to reduce the pulmonary capillary pressure. So therefore it helps with pulmonary edema. Then you can use inotropic drugs. So you can have the positive inotropic drugs, which is going to have increase in the myocardial contractility, which can cause increase in your cardiac output. So you can use drugs like dobutamine. Vasoconstrictors, when the BP is going to be too low to support the BP of this person, you can use vasoconstrictors like dopamine, epinephrine and norepinephrine can be used to support the blood pressure in these patients.